I think this is sort of general and people would agree. It is mainly after primary, one of the things is after primary induction failure, MRD positivity after initial therapy. Definitely everyone should have a consultation after CR1, your first relapse, and CR2 and beyond. Now here, this is the NMDP here, they've defined adult as more than 40 years, but again, obviously, depending upon where you work, whether pediatric or adult, I think you would still do an HLA typing right up front. Now, why do we want to do a transplant in ALL? We know that probably 75 to 85% of the patients will achieve a CR anyways, but relapse risk is very high, and we have seen that once adult patients relapse, their outcomes are not good. Then there is potential benefit over chemotherapy. One is the myeloablative chemoradiotherapy, but again, age is a factor. If a patient is more than 40, 45, after having gone through an ALL induction and then giving myeloablative transplant will be too toxic, and the morbidity from a myeloablative transplant would probably negate the benefit they would gain from the transplant. The second is the graft versus leukemia effect. So that should be quite strong. And balance of the risks, which I talked about, which is early treatment-related toxicity, and late, which is GVHD. Now, conditioning regime. Now, the standard conditioning regime is cyclophosphamide. We give it 60 for 2 days, followed by 12-grade TBI. Now, that is the standard regime. People have looked into, now this is one trial which has looked at adding etoposide and TBI. So there were 4 groups. So what they did was they did cyclophosphamide plus TBI 12-gray. They did etoposide plus TBI 12-gray. They did cyclophosphamide plus etoposide plus TBI more than 13-gray, etoposide more than 13-gray. Now, in this trial, they did not find any difference or any advantage. In fact, the toxicity levels were much higher, and they concluded that Cy-TBI is the standard protocol. There has been some UK data as well, where they have used, within the trial itself, they have used Cy-TBI 12-gray, etoposide TBI 12-gray. They have used etoposide TBI more than 13-gray, equal to 13-gray, and Cy-TBI more than 13-gray. Now, there is only one population of patients where they thought that substituting etoposide or substituting etoposide for cyclo may be useful, or using more than 13 TBI with Cy would be useful, but these are only patients if they are in CR2. So here they found that if you use etoposide instead of Cy with same 12-grade TBI, or you Cy with more than 13-grade TBI, if the patient is CR2, it may be beneficial. Age more than 45, RIG transplants, but we all know that the RIG transplant, GVL, is not as good as that of a myeloablative transplant. These patients will not be able to tolerate extensive and very heavy chemotherapy. These patients mostly are relapsed in CR2, and therefore the only hope that we can offer them is some modest GVL through a RIG transplant. Most commonly, we would probably use Flu-Bu-ATG or Flu-Mel, one of these protocols, depending whether it's a SIB or whether it is a MUD and your level of matching. Now, this is NMDP data. This is, again, overall survival. And you can see the bottom line is 87 to 2003. The top line is 2013 to 2015. And clearly, we can see that the outcomes are getting better decade on decade. And this is mainly because we are probably getting better at how we are identifying the patients, treating them in dedicated units, the nursing, the antibiotics. I think all of these are making a difference. This is again data. On the left is your marrow. So donor source is a marrow. On the right, your donor source is peripheral blood. These are unrelated donors again. And again, it says that first CR patients do well. The bottom 2 lines, the middle or the bottom, are the second CR and advanced disease. So needless to say that earlier you do the transplant, better is the outcome. Now, this is interesting. So this is now pediatric inspired therapy versus allo, okay, in pH negative. So you've got patients who have been treated on the adult protocol and have had a transplant versus you treat the patient on a pediatric protocol. What is the outcome? And here it clearly says that if you treat the patient on a pediatric protocol, these patients are going to do better. So that is now the first evidence to say that pediatric inspired protocols may be better in certain patients, and you may not need to put them for a transplant. Now, coming to the MRC data. Now, there's always been contention of, do you need to transplant all patients who are a standard risk or high risk if they're in CR? Do you do a mud transplant? Do you do a sibling transplant? So this is one of the trials, big trial, MRC trial. Almost 2,000 patients accrued between 93 and 2006. Again, you can look at the ages. So 15 to 59. So they've excluded the 60 plus. Patients were treated with 2 inductions if they were in CR1, and if they had a sibling, they went straight for a transplant. If no donor, patients were randomized to chemo versus auto transplant. Okay? And pH positive patients underwent transplant if they had a sibling or a mud. Okay? So what did they find? So pH negative, okay, with donor and without donor. So if you had a sibling, actually, with a donor, you did better. Standard risk with donor, you did better. High risk with donor didn't make any significant difference. Chemo only versus auto only, maybe chemo is better. So this was one trial which showed that if you did a transplant for standard risk in CR1 with a sibling, the outcomes were better. This is one trial. There have been other trials which have shown that there is no benefit. Now, here comes the role of the MRD. Which patients are you going to select which will go for transplant? So, role of allogenic transplant in adult patients with pH negative ALLs. Now here, it's a busy slide. But if I have to tell you the top and bottom, the top line is MRD less than 10 raised to minus 3. No transplant. Okay, this is CR1, pH negative, MRD negative, no transplant. They are doing well. The line just below it is MRD less than 10 raised to minus 3, again MRD negative, but with transplant. Now, the difference between the two curves is very small. It is almost reaching significance, almost. But the authors here have said is, given the transplant-related morbidity, given the infections, given the mortality associated with the transplant, the difference is not that significant if you take all of these into consideration. So the authors here have clearly concluded that if you have got pH negative ALL, MRD is negative, CR1, you may not need to go for transplant and only maintenance should be enough. So this is your pH negative ALL. What about T-ALLs? Now T-ALL, as we all know, T's do poorer than B's. Therefore, naturally T's all go for transplants. But what happens within the T-cell ALL group itself? And this is one data again, MRC trial, which patients with T-ALLs have been transplanted, and you have got patients who have not been transplanted. And here is a significant difference. Patients with T-ALL who had a donor who have been transplanted have done significantly better than those who have not had a donor. Within the T-cell phenotype itself, all of us know that you've got the early T-cell precursor ALLs, which is a particularly high-risk subtype. And the red line is the early T-cell precursors, and the blue line is all the other, like the mature T-cells and else. And you can see that it's the other way. You can see the red non-ETP actually do much better than the blue ETP ALLs. So, transplant for T-cell ALLs. What about pH positive ALLs? Traditionally, pH positive ALLs, high risk transplant. It was a no-brainer. Straight away, you have to go for transplant. Now, this is a study which has looked at patients who have not had a transplant, They have been treated only with TKIs in the induction, and they have looked at their outcomes. Okay? The graph on the left is at CR, the graph on the right is 3 months after CR. The red line are the patients who are in complete molecular remission or who have had a CMR. The other two are no MMR and MMR. And you can see that if patients have achieved a CMR, they actually do quite well. And these are patients who have not had a transplant. They're only on TKI and chemotherapy with TKI maintenance. What about if we compare transplants in pH positive in the imatinib era, TKI era, and non-TKI era? Has it actually made a difference? So yes, it has made a difference. The top one line, the overall survival, progression-free survival is much better in patients whom you have used the TKI along with the induction chemotherapy versus if you have not used TKI. The bottom shows your relapse risk. So those in which there was no TKI, the relapse risk was very, very high. So if you have to put all of this together, how are we actually going to treat ALL? Because there are a lot of variables here now. So if you look at the top part, A is the pre-treatment prognostic factors. And here it is your molecular markers. Is it pH positive? Is it pH negative? Is it pH like ALL? Have you done your molecular typing? These are the patients where you're going to have molecular and cytogenetic heterogeneity, and you have to select your induction chemotherapy accordingly. Then your first is your remission induction, your chemotherapy. So pediatric-based protocols. Are you going to add rituximab for your CD20s? There is some data that if you add dasatinib for the pH like ALLs, your CRs are better. You have the nelarabine for the TALLs. So all of these newer molecules would be slotting into this remission induction phase. Then you've got a treatment decision. Now this will be based on your MRD. Most of this will be based on MRD, whether they're going to go for stem cell transplant, whether they're going to go for maintenance. The bottom is also going to be similar because it is going to be MRD based for remission induction, treatment decision for transplants. If they go into transplant, are you give them DLIs? Which generation of TKIs are you going to give them, especially if it's pH positive? Recently in ASH, there was a paper for adults 60 plus where they use ponatinib and dex with excellent responses. And these patients, group of patients, were deemed unsuitable for chemotherapy. Just ponatinib and dex had fantastic remission rates in the 60 plus. So again, what treatment, which age group are we using, what is the disease biology of the disease? So all of these things are going to come as more knowledge is accrued and more trials are being considered for different age groups. I haven't touched too much on the newer agents. The CAR T cells has revolutionized ALLs. You have got CD19.
Dr. Samir, we are running short of time.
It's my last slide. These are the antibodies which we use and have lot of these are in trials as well. And therefore, there's still a need to see where we can slot this in the initial remission induction phase, or are these going to be only for relapses? So I think if to summarize, I would say that all high-risk young adults with available donors should undergo an allotransplant in CR1. Recent studies have suggested that the ETP ALLs and pH-like ALL be treated as high risk and be offered allotransplant during CR1. Allotransplant in standard risk adults is less clear, but this can be looked at with the MRD to guide the decision. MRD appears to now becoming standard of care, definitely in pediatric, but now also in adults. And the role of novel agents upfront will change the landscape of the treatment. So with that, I'll stop here. Thank you.
Thank you, Dr.